Hello, everybody, and thank you for joining us for today's program on hereditary angioedema. My name is Dr. Aleena Banerji. I'm a professor at Harvard Medical School and clinical director of the Allergy and Immunology Clinic at Massachusetts General Hospital in Boston, Massachusetts. We will be talking about hereditary angioedema for the next 30 minutes, and I encourage all of you to leave questions and comments throughout the podcast that we'll hopefully try to address and incorporate into our discussion today. Also, we would love to hear where you're from, so please pop in a quick hello and share where you're from in the chat. And I am joined and honored to be joined by both Dr. William Lumry, who is a colleague and friend, as well as Pam Curry, who is a patient living with hereditary angioedema. Dr. Lumry, over to you. It'd be great to hear a little bit about you.
Thanks, Aleena. It's a pleasure to be here, and thank you all for joining us. My name is Bill Lumry. I'm a practicing allergist and immunologist in Dallas, Texas. I have a clinical appointment as a professor of internal medicine at Southwestern Medical School at the University of Texas. I've been involved in the HAE field for more than 30 years, and I'm really happy with where we are with our therapies nowadays, but I think we can still do better. Pam?
And I'm Pam. I'm a patient who has HAE, and I've been living with it, of course, all my life. But my diagnosis didn't happen until, I would say, the mid-1990s. So I had lived with it for a long time before we ever figured out what it is. And just here to share or to talk about what that means and the treatments that they'll talk, Dr. Banerji and Dr. Lumry will talk about too.
Wonderful. Thank you, Bill, and thank you, Pam. I'm honored to be a part of this session with both of you today. So we'll start a little by talking about the burden of HAE from both the physician and patient perspective, and then we'll talk a little bit about the challenges with treatment, the current treatment options, and finish up by talking about what's on the horizon and how will some of these new treatments address some of the challenges that we're talking about. So first, Bill, maybe you can tell us a little bit. We know that the burden of disease for patients with HAE remains high. It's something that you and I actually have a particular interest in. So what do your patients usually describe in terms of the impact from their symptoms or swelling from HAE in their daily lives, or maybe even separately, the impact on their daily lives knowing that they have HAE even when they aren't having an attack?
Well, I think it's interesting, and I'm glad that Pam has joined us because she can certainly share from her standpoint what this disorder means to her and has meant to her family or her daughters as well. The burden that I see that seems to it certainly would bother me most, is the unpredictability of the disease. The fact that you can have an attack for apparently no reason at any particular time, at any particular place. And that attack may be anywhere from just moderately disabling if your hand or your foot swells up to life-threatening if you have a swell inside of your mouth or inside of your airway. That unpredictability, I think, makes patients that have HAE have a greater level of anxiety. And if they don't feel like that they can control the disease, which fortunately we can now with modern therapy, there's a significant amount of depression that can go along with that lack of control. As far as a day-to-day life, obviously, again, we've got great medications that have been able to prevent many of the attacks that patients used to experience, but still breakthrough attacks do occur. And again, those breakthrough attacks are quite unpredictable. And again, that angst of when is the next attack going to happen? Will I have my on-demand treatment available to use with me at that particular time? I think all of that adds up to a significant burden beyond other obvious things like the financial burden, the burden on the family, the burden on educational process and or employment. But I think just the unpredictability and the potential that you might have an attack that could end your life is huge for these patients.
Thanks, Bill. I really appreciate that perspective. And, burden of disease is so multifaceted and there's so many aspects of it. And sometimes we even forget that there is the idea that they might want to go on vacation and how they think about that, or education, as things that people that don't have HAE don't even give a second thought to, but really changes the lives of our patients with HAE. And maybe to that extent, Pam, could you tell us a little bit from your perspective, having heard what Dr. Lumry reviewed, really how does HAE impact your day-to-day and your overall quality of life? We'd love to hear a little bit from your perspective.
Well, I think that the key word that Dr. Lumry used is unpredictability, because that, to me, is one of the hardest things about HAE, is that it's so unpredictable, and usually it's going to show up when you don't want it to, when there are important events, when you've had something planned like a vacation or something that you really want to go to, or involving your family, and then you feel like, okay, I've let my family down too, and the emotional toll that takes on you. Because I've been through all of those things. When I was diagnosed, there wasn't any kind of treatment available, so we had to go through every attack from beginning to end, and that took us out for, depending on where the attack was, anywhere from a couple of days to maybe a whole week, for the swelling to actually go all the way down. So we've come a long way, but it is still there. It is still unpredictable. And I don't think that will ever change, despite the wonderful things that the medical field is doing for us. And one thing that causes so many of us to have HAE attacks is stress. So, you compound that with missing a family event, or your kids being upset because you can't come to something at school because you're having, you're sick and you can't make it. And that just adds up to even more stress for your lives.
Yeah, thank you, Pam. And I agree, the highlighted word of unpredictability is really such an important aspect of this. And, you could be doing perfectly okay and wake up with your hand swollen. And while that might not be life-threatening, it certainly does impact driving, using your computer, using your phone, things that are just part of our everyday that become very difficult. And then the other aspect that we didn't really talk about is that this is a life-threatening condition. You can wake up not having done anything that you shouldn't be doing and develop throat swelling. And, that really is life-threatening. And so, Pam, have you ever had, more severe attacks? And has that really played a role in how you think about your day-to-day and your overall quality of life?
I have had a couple that involve a laryngeal attack, and yeah, that is scary, because number one, unlike, say, you have a facial attack where your face is swelling and you can see that, but you can't really tell with, your throat, by yourself. I'm sure one of you could look and you could tell if that's happening, but it is a scary moment. It's because you wonder then too, is it because I'm just scared that my throat is tightening up, or is it that I'm really having that throat attack? So you do take those very seriously. I've had to go to the hospital with abdominal attacks, but I haven't ever had to go for anything else. But it is something you always keep in mind.
No, thank you, Pam, and I appreciate you sharing, a lot of these personal things so that we can all learn and understand, from your perspective and from a patient perspective, how these things impact our day to day. And so, maybe we can move a little bit to now thinking about all of these aspects that do impact our daily life. Bill, we care for patients. We want them to be able to live a normal life. And certainly we have made treatment advances. But from your perspective, thinking about the on-demand treatment options and the long-term prophylactic treatment options, what continues to contribute to treatment challenges, even though we've moved the needle?
Well, we have and I think our audience knows this, we've come a long way. In the last 12 years, we've had 8 different HAE treatments, 4 on demand and 4 prophylactic treatments approved in the United States for use, and that has literally changed the lives and given the lives back to many of our patients that suffer and live with HAE. But we're not done yet. The challenges that have been reported to me, I mean, from my standpoint, a huge challenge and unmet need is our ability to take care of the little ones. The pediatric medications are just not there yet, particularly the on-demand medications. They still have to be administered intravenously, which is a huge issue for a small child. We do have a prophylactic medication that can be given subcutaneously every month to down to age 2, and that's made a big difference in the kids that were having significant problems before that was available. But we still have room to work in the pediatric space. As far as the adults, we only have, well, we have really 3 different on-demand medications that are commonly used. 4th is not so much used, but they're all parenteral. They're all given either intravenously or subcutaneously, which is a challenge for some patients. They don't like needles. They don't want to have to carry a kit around with them so that they can administer an IV or administer a shot if they're having an attack. And we know from recent studies that many of the attacks that patients have are just simply not treated because they don't have their on-demand medication with them. They left it at home. They don't want to carry it. And because of that, the attacks are more severe and maybe require more healthcare utilization because the attacks aren't treated. From the standpoint of the prophylactic medications, they're injectable, 1 intravenously, 2 subcutaneously, and then we do have 1 oral agent. Not everything works for everybody. So some of the problems with our treatments is that we offer something, it doesn't work, or there's a side effect, and then we have to move on to something else. But fortunately, we do have very effective medications, and typically a patient that does need preventive therapy can find something that works well for them, doesn't cause significant side effect issues, and helps decrease rather dramatically the frequency of the attacks that they're experiencing. Probably another challenge that we deal with in the medical office is getting access to these drugs for our patients. There's a lot of authorization that has to go into effect before an insurance company or other payer will allow these drugs to be prescribed to these patients. And oftentimes that causes not only stress within our offices, but stress with the patients wondering whether they're going to be able to continue to get the medication that's working well for them. So we've come a long way, but I think we've still got a distance to go to make this easy for everybody to treat and effective with what they use.
No, thank you, Bill. And I have very similar experience. You know, I think the pediatric population, we have a long way to go. And certainly the treatments that we do have, we still face challenges with getting approvals, getting insurance approval. You know, we've had patients who are on long-term prophylaxis and doing extremely well. And then the insurance company denies any sort of on-demand treatment because they say, well, the patient has not had an attack in the last 6 months. And, you know, it's similar to someone with peanut allergy not getting an EpiPen. I mean, it just doesn't make sense to me. And so why these challenges exist, you know, we still have work to do. So maybe Pam, I can turn to you similarly. You know, you probably have experienced a lot of what Bill is talking about, but maybe you could share a little bit from your perspective. You know, what is aspects of the treatments you're using or have used or have tried are challenging, and how have those conversations been, which is also an important aspect of this, is, you know, how do you navigate that conversation with the person that's your doctor that's taking care of you and your HAE?
Well, from you know, how you administer it, that is one thing that I think everybody would take into account. And Dr. Lumry was talking about if you're comfortable with the IV, you know, that was the first treatments that were available, and then the sub-Q, and now, as you mentioned, the oral. So you take a look at that and think, okay, well, how does that fit into my life, and how does that fit into what I'll be doing, and can I manage that well? What if I have to be gone? Can I take that with me, and how hard will it be to take care of it when I do? if it has to be kept at a certain temperature, or any other requirements to keep that medicine to be effective. And then I think also what you guys were talking about as far as the financial burden, I think it's always scary for us as patients not to know, is the insurance company going to approve this? How am I going to make things happen if that doesn't happen? Am I just going to be without medicine again? Because I've lived like that before. But you do wonder, is that what will happen? And sometimes it is confusing as to, they've been giving you the medicine and then they'll stop, and then you're thinking, why does that happen? And it'll take a while to get it back. And that's something, thank goodness, that I'm not having to deal with all of that. The doctor's office is, but staying in touch with them and trying to provide whatever they need is also important about how your life is going and how those attacks are fitting in or affecting your life. So there's a broad range of subjects as far as what we look at, as far as the impact on choosing a treatment and what will be best for you. And for everybody, that's going to be different.
Yeah. No, and I really appreciate the perspective of having these drugs approved. Why January? I mean, I know it's a new year, but every January, insurance companies ask for new approvals as if something has changed in a genetic disease and something that you're born with, and really it doesn't make any sense. Bill, if you don't mind, maybe one other question I have for you from your perspective around treatment challenges is, and this is something I face a lot, is, guidelines encourage all patients to have at least 2 doses of on-demand treatment and to treat as early as possible and to treat all attacks. And I find that doesn't always happen. And I'm curious from your perspective if you're seeing that and how you might have navigated that challenge.
We are seeing that, and you're right. The guidelines do recommend carry your 2 on-demand treatments with you at all times. Treat every attack, and treat every attack as early as you can. And what we've found, and I think is as I mentioned, maybe 60% of attacks are actually treated. Patients in a recent patient survey, that they often will wait to see if an attack is going to be, quote, bad, before they use one of their precious on-demand medications up. Speaking of the payer challenges, some of the payers, again, not only are denying on-demand medication to patients that are well controlled, but they're also limiting the number of on-demand medications that a patient can have per month. So if a patient only has 3 syringes to use a month and they have what they perceive as a mild attack, don't feel like they want to, quote, waste a treatment on an attack that may not be life-threatening or particularly disabling. And that's certainly a challenge. The other issues what I have done is to try to encourage people to do what the guidelines say, that we know that attacks can start mild and turn into something that's very hard to control. We do know that the earlier you treat, the sooner you turn off the spigot, if you will, the sooner the swelling is going to stop and dissipate eventually. And that still doesn't sometimes translate. And again, I think part of it is because of, again, the challenges of the injectable medications for on-demand treatment. You have to find a place that's private to be able to give yourself a shot. You have to find a place that's reasonably clean if you're going to use an IV. You've got to carry these things in a proper way that they don't degrade if you carry them around with you all the time. So I think there's a lot of issues about our current therapeutic regimen that prevents patients from actually being able to abide by the guidelines. But it's a challenge, absolutely.
I agree.
So Pam, or rather Aleena, we've been talking about attacks as the physical manifestation of this disease, and obviously there's other psychological issues that go along with that unpredictability of the disease. But what do you feel like that the ability or inability to control attack frequency and then the associated treatment challenges surrounding that, how that impacts the burden as you see it, and generally the quality of life with patients that have HAE?
Yeah. Bill, it's a good question. And I think that, decreasing attacks is critically important to burden of disease and quality of life. But at the same time, I think it's just one aspect of it because as we've heard from Pam and what we've seen is we can have, individuals on long-term prophylaxis and they may not have had an attack in a year, but the unpredictability remains and they could still have an attack tomorrow. The attack tomorrow could be life-threatening. The attack tomorrow could prevent them from, going on vacation or showing up for that family event. And that is still such an important part of the burden of disease or the quality of life that we still have to address. And it kind of gets at the idea that if we could treat on-demand attacks easier, simpler, didn't have to find a place to inject, are there other ways that we can think about treating an attack as quickly as possible when it occurs that can continue to move the needle further? I think we'll continue to improve burden of disease and quality of life. And then certainly there are other aspects of this beyond, the treatment challenges and the attack frequency, which you had mentioned. We see a lot of anxiety and depression because of the burden of having this disease. And so there are all these other aspects in thinking about a patient as a whole or an individual as a whole and not just their HAE. And so I think there are other aspects of this. But, if I could ask Pam actually as a patient who has been managing this or dealing with this for years, how important from your perspective is reducing attack frequency or the treatment challenges that we spoke about, really from your perspective?
I think it's important because when you treat it, when you have an attack, your body is still going through that attack and it still has to resolve all the things that you go through physically. So when you reduce the attacks, then you're giving your body that break I think it needs. I mean, that was the first thing I started realizing as things started getting better is that, hey, I'm not having this every week or, however many days, and I feel a little bit different now. So if you're having that attack and you can stop it where it is, that's great. You still, though, are having all those other symptoms and dealing with whatever toll that takes. And it might be something that, like you said, is going to keep you away from something that you really want to do. So I do think that is important.
Thank you, Pam. So, as we're kind of closing in our half hour, let's turn to treatment and kind of where we're going with treatments in the future. Bill, can you tell us a little bit about how the management of HAE has changed in the past decade? I know we've talked about some of the newer treatments, but can you just summarize that for us as we move into talking a little bit about the future of treatment?
Sure. When we think back to before 2008, what we had to offer our patients were androgenic steroids, androgens, which might raise the level of C1 inhibitor. And we also had fresh frozen plasma, which has C1 inhibitor in it. And that's what we had. And other than that, we had time and support. If your airway closed, you got intubated. If you had pain in your belly, you got narcotics and antiemetics. Since 2008, and I'll push through this because I want to get to some of the newer things that are going to be talked about at the EAACI conference coming up next week. Initially, as Pam mentioned, we had a C1 inhibitor infusion that was used for prophylaxis. That was the first thing that was approved. Shortly thereafter, another C1 inhibitor concentrate was approved for on-demand therapy, again, IV treatment. Then a couple of years later, the Catabant, Firazyr, a subcutaneous on-demand medication was released and approved, and that really changed things because again it released people from having to do IVs to treat attacks or go to the hospital to get an IV to treat an attack. Then for several years nothing really changed. Then in about 2017 we got subcutaneous C1 inhibitor, which replaced the IV C1 inhibitor, making it much easier for patients to deliver that drug. Then 1 year later, a drug that blocks plasma kallikrein, one of the important steps in producing bradykinin, which causes the swelling, was introduced as a subcutaneous agent delivered every 2 weeks. Since then, most recently, we've had an oral agent. In fact, it's been 4 years now since the oral agent was approved, which is now available for prophylactic therapy. So that's basically what's happened. Those are the sort of 8 drugs that we've been able to get approved in the last 12 years, and they've really changed the face of things. But Aleena, why don't you tell us a little bit about how you talk to your patients about therapies, whether it's on-demand therapies, whether it's prophylaxis, and how you kind of set up the expectations for what they should achieve when they begin these drugs.
Yeah, no, thank you, Bill, for walking us through that. And to me, the core principle around treatment, whether it's on demand or prophylaxis, is really a two-way conversation. There's no one size fits all. It's really about the patient. Whatever decision we make today, we will continue to have an ongoing conversation. But all patients should have on demand. All patients are eligible for long-term prophylaxis. And then we talk a little bit about what is their day-to-day now? How are those treatments working? Do they live close to an emergency room? And really think about the person as a whole. And so maybe just to kind of finish up, let's move a little bit towards the newer treatments that are in trials. And we'll pull up a slide. But quickly, Pam, as we're going to review the drugs that are on this slide, what do you feel are important features from your perspective as a patient of treatments as they're being developed? Is it mechanism? Is it safety? Is it, administering it orally? What's important to you?
Yes, all of those things are important to us because I think that the easier it is to use and the easier it is to take with you wherever you need it, that's going to increase the usage, which Dr. Lumry said was 60% get treated. Well, if more get treated, then everybody's having better results and feeling better. So I think those are all important things, and just, it's amazing what's been able to be done, and it's amazing to see this list that you've got here as well.
No, I agree. It is amazing as a clinician knowing that all of these therapies are on the horizon. And to kind of briefly mention, sebetralstat is an oral inhibitor of plasma kallikrein that we can give on demand. And the phase 3 trial has very promising data. Decryptobant, which is an oral inhibitor of bradykinin at the B2 receptor, again, oral, just getting started with their phase 3 study. And then 2 other long-term prophylactic agents that I want to quickly mention, and then move over to Bill, is garadacimab, which is a monoclonal antibody targeting factor 12A, given at regular monthly intervals as subcutaneous injections, showing very promising data for long-term prophylaxis. And then donidalorsen, which is an investigational antisense therapy for long-term prophylaxis, evaluated at every 4 weeks and every 8 weeks, again, showing very promising data for long-term prophylaxis. And we'll hear more about this at the upcoming conference. And maybe, Bill, I'll turn it over to you to talk a little bit about the other therapies on this slide.
Sure. I think beyond ease of administration, as Pam pointed out, whether it's oral, also the interval between administration, particularly with the subcutaneous drugs, may be important for patients going forward. We started out at an every 3-day interval, and then we moved to an every 2-week interval, and now some patients are able to take their preventive medications monthly. Well, as you pointed out, garadacimab is going to be monthly from the very beginning. Donidalorsen will be monthly from the beginning, and then maybe every 2 months after that. 2 other products have very, very long half-lives. The STAR-0215 product is a monoclonal antibody that works similar to lanadelumab, and it may be able to be administered every 3 or even every 6 months. And the ADX324, which is in very early stages of development, is looking at a potential administration every 6 or 12 months, if you can believe that. The decryptobant, which you mentioned for on-demand therapy, is also being studied as an oral preventive therapy, which will be given as 1 pill once daily. The clinical trials for that approval are just now getting cranked up, and we'll see whether that works out for them. We also have a potential quasi-cure for the disease. There's a company that is developing a gene editing technology through a CRISPR-Cas9 technique to knock out one of the genes that's important in producing prekallikrein, which is vital for kallikrein to be produced, which, as I mentioned, is an important piece of the contact cascade, which leads to the bradykinin production. Their early data looks very good with patients after the editing is done within several months being able to wean off of their other prophylactic medications and be essentially attack-free. So there's a lot of stuff that's on the horizon. Some of this is a year out, some of it's 5 years out, but again, it's very exciting to see that the development is still ongoing.
Well, thank you, Pam, and thank you, Bill, for taking the time today and sharing your thoughts. Thank you again to the audience as well. And for more information on HAE and the latest data on new and emerging treatments, please keep a lookout for the accredited educational activity on medscape.org in the next month. Thank you.
Thank you.